This week on the BackTable Podcast.
Forensic rhinoplasty is what I call it. Like when you open the nose up, you have to look at how those tip cartilages are constructed and see if all the assumptions you made based on the way the nose looks are correct. One of the challenging things is people have a way, I do tips this way. You can't do this. This is the way I do my tips every time. They're all different. And so you have to come in thinking, okay, this is what I thought was going on here. But look, all of a sudden I see this really concave lateral crus on the left and not on the right. And I thought the septum was deviated to the left, and that's what was driving this tip asymmetry. And you have to pivot and understand what changes you're going to make. I think that's the first thing. You have to kind of verify that the cephalic malposition and that kind of short axis rotation I was talking about are correct with the lateral crura, and then make sure that your plan is correct. So I think that's where it starts. You come in with the plan, you double check your plan once the skin's up, and you do that in a way with no retraction on the nose. You're not pulling, you've just folded the skin back and just looking at them, laying how they live on their face, and making sure that's the same.
Hello, everyone, and welcome to the BackTable ENT Podcast, where we discuss all things ENT. We bring you the best and brightest in our field with the hope that you can take something from our show to your practice. My name is Gopi Shah. I'm a pediatric ENT, and I have such a special guest today. I have Dr. Patrick Cleveland. He's a facial plastic surgeon in West Palm Beach, Florida. He completed his otolaryngology residency at UT Southwestern in Dallas, Texas, and his fellowship at NYU in Manhattan. And he is here today to talk to us about rhinoplasty. Welcome to the show, Patrick. How are you?
Hey, I'm wonderful, Gopi. Thank you for having me.
I'm so happy you're here. So just to kind of, for the audience, Patrick, I remember interviewing you for residency.
Is that right?
Yes, I remember it because I was with Teresa Chan, and I remember,
Right.
Yes,
Yeah.
I remember interviewing you. And I remember when you were an intern, I think when you were at Children's rotating, I think you popped in to see what we were doing. I think we were doing like a fest or something, and you had those glasses on. I don't know if you remember those glasses.
Yeah, my rec specs.
Yes.
I think I was an away rotator at that point. That was like med school.
Yeah, no, I do remember the rec specs, and then, getting to the opportunity to work with you, which was great. So happy you're here. It's so awesome to have you.
And, Gopi, this is kind of like apropos because, believe it or not, you're a huge part of my love of rhinoplasty, because when I was a senior
how
on
does
Children's,
because for full disclosure, when I sent you the questions on this episode, you had to rephrase some of them because some of them, in terms of basic stuff, we had to rephrase the question. So
no, when I was like senior resident on your service, and I used to come in, we had a full tonsil day. You'd like look at me and be like, do you want to go run over and see Cochran do rhinoplasty so I can just blow through these and you can do what you want to do? And I'm like, yeah, that sounds great.
Yeah, that's right. I was like, there's some stuff I think Patrick might be more interested in than like tonsil number 257, but So just for our audience, can you tell us a little bit about yourself and your practice?
Yeah, absolutely. So, I'm a facial plastic surgeon here in Florida, and, specialize in rhinoplasty and facelift. That's 90+% of my practice. As far as the rhinoplasty side goes, I would say 75% is primary rhinoplasty, 25% is revision, the vast majority being cosmetic. I do a fair bit of functional rhinoplasty, oftentimes kind of tied with the cosmetic changes. And I honestly think like every rhinoplasty is a functional rhinoplasty. You can't do a rhinoplasty thinking this is going to look great, but I'm going to like wreck the valves and cause them to collapse, So I think you're always thinking like, okay, what's their breathing beforehand? Where's the airway narrow? And so that kind of goes in every case.
Awesome. Okay, well, we're just going to jump right into it then. So in terms of like when you're talking to your patients, are there risk factors or, red flags that you ask in their history that make them higher risk for rhinoplasty?
Yeah, obviously prior surgery, you always got to make sure they don't have septal perfs. They're non-compliant patients. You're always kind of worried like, okay, is what we're talking about resonating? Is this something they're going to in one ear and out the other? Because to me, rhinoplasty is what makes it so unique, and I think where a lot of people struggle is it's not the difference between this and a tonsillectomy. The tonsils are out or they're not, right? And with rhinoplasty, I'm operating to a subjective endpoint. And so I have to first identify where that endpoint is and then be honest with myself, can I meet that endpoint? And I think a lot of people think, oh, yep, I can fix this nose. But the patient's idea of where they want it to end, I mean, there's a spectrum of what looks good. So to me, so much of that first encounter is trying to ascertain like where their mind is at and that we are on the same page. So, if I have someone who has body dysmorphic disorder, if I have someone, bipolar disorder, psychiatric comorbidities where, their opinion might change flippantly. Like those are patients that big red flag, in men, like the Simon patient's a real thing, that single immature male that is, overly expectant and narcissistic. Like they're, you see them and you have to just say, I don't think I can make you happy, and that's kind of a difficult dance because, if you tell them no, like they don't take it well.
Yeah. In terms of, the patients that come in, you'd mentioned, endpoints, and obviously we think of cosmetic endpoints. What percentage of your patients who come in also have functional concerns, or, maybe you're digging through the history and there is a component of nasal obstruction, but they may not present initially and realize, hey, this is all kind of related?
Yeah, I would say probably a third. I think patients with purely straight septums are rare. There's a lot of patients where they have a little bit of bow in the septum and it doesn't really affect their breathing, but it definitely affects your cartilage management during a case. The same thing with valve support. You see people where they don't have valve collapse talking like this, but as soon as you stress the valve and have them inspired deeply, they have that. And then you kind of dig in. They're like, oh yeah, when I exercise, my mouth always gets dry. Like I never can breathe through my nose. And so like, you have to be cognizant because you're taking down a hump and you're going to be, taking down that area from a cosmetic standpoint. You need to reinforce it and repair it so that they're not going to now have physiologic collapse while they're just sitting there breathing afterwards.
Yeah. And you mentioned 75% of your patients come in for primary rhinoplasty, 25% have come in for revision. What percentage, as a peds person, we do closed reductions primarily. I feel like, we see that because of, kids have trauma to the, playing basketball, get elbowed, whatever. What percentage do you see those patients that have had a history of closed reduction that end up in your office? What percentage of those patients come in?
I would say a handful a year.
Okay. I'm like, okay.
with a more distant history, probably more. But like I have, like some of the basketball teams, like will have like around the area, like college basketball teams and stuff will call us and send patients to take an elbow. I feel like they get one or two of those a year. Basketball is definitely a high risk sport for nose injury. And you think of football as injuries, but like they're wearing a mask, so their noses are usually pretty safe. The rest of their body, for me, it's basketball. And then, I also get a lot of, believe it or not, like equestrian injuries around here. So horseback riding, they take, a jump wrong or something and the nose smashes the back of the horse. And so, oftentimes with those, if there is obvious asymmetry of the bones, like I'll do a closed reduction up front and then follow them out to 6 months and kind of counsel them that, listen, like probably a third of the time, this will take care of everything. A third of the time, you're going to still need surgery, but we're going to be setting ourselves up in an easier place to do that surgery if we get the bones back instead of having to do it all at that time. And then a third of the time, it just doesn't matter. Like there's a little non-displaced fracture.
In terms of the patients you had mentioned that might be red flags, a potential for body dysmorphism, or for example, in terms of kind of, being aware of that, teasing that out, is that something, one, did you learn about that more in fellowship? And two, what are some practical things that you might hear somebody say, or, what's going to kind of, bring that to your attention?
So trust your staff. I think that's one, because everyone puts on their best face for you. So, if there's weird vibes on phone calls when they're there, like it gets flagged on my schedule just so I can kind of really take time to like look into it. I also kind of just usually undersell what we're going to do if I think that it's there, to see like, are they going to obsess over this 0.5 millimeter difference, especially during the image morphing. I will purposely underdo the picture a tiny bit to where it still looks good, but it's not necessarily everything I think I can get out of the case to kind of read that. And I remember Rod Rourke told me one time, like, if you're sitting one of these patients like away and finding them once a month, you're doing pretty good. Like, I think that's you should be saying no sometimes. You should be steering, you'd be like, no, this is not the right case, because you're not helping them. You're actually causing them just more emotional stress. You're gonna want to retire 10 years earlier if you're having a practice full of these patients driving you crazy.
Yeah, no, that's such a good point. Trust your staff, because you're right. They're going to be the face. That's the first interaction, which is usually the true colors. Talk to me about your exam, and can you take me through how you perform your nasal analysis?
Yeah, absolutely. So I do a kind of a top-down approach, and I think when you're coming top-down, you kind of have to think of it three-dimensionally. So start at the radix. What's the radix position as far as the low spot? Is it high up in the brows, like a Roman nose, really, really low? Coming out of the nasal bones, is there a hump? Is there contour irregularities? Are the bones wide and flared? What's the dorsal aesthetic line looking like? Coming down to the nose, is it nice and straight? Then coming down to the mid-vault, do I see evidence of collapse? Again, is there a cartilaginous component to the hump? Also down towards the interseptal angle, is it prominent, pushing the tip down? As I get down to the super tip, I'm usually looking, is there a break? Is there a prominent anterior septal angle there? What's the relationship between the dorsum and the tip cartilages? And then once you get on the tip, I think you really have to think about a lot of microanatomy. So more so than just what's the projection and rotation that we all think of. Okay, yeah, it's bulbous. There's some projection issues. There's under-rotated nose. Beyond that, though, you really have to look, is there cephalic malposition of the cartilage? So the actual three-dimensional spatial location of the lateral crus is crucially important to any sort of tip dynamic things you're doing. And so if you can imagine, and I know for the listeners, I can't see this, but on the video, like if the cartilages are naturally at about a 45-degree angle, from midline, when you get cephalic malposition, they come more vertically, and you can't just trim cartilage away here and expect bulbosity to go away. So you're going to have to relocate the tip to make that angle lower with the lateral crural steel, probably make your cut differently. And sometimes you have to reposition them entirely if they're very vertically oriented. By that same token, how those cartilages are rotated in space, you have to be cognizant of, because if you have these cartilages that are like really flat, kind of almost in like a coronal plane, they're going, you can trim them, but they're still not creating that curvature around the ala and around the tip that you want. So you have to rotate them more into an axial plane. So, all of those things kind of go through my mind. Is it a boxy tip? And then that follows down to the columella, that whole boomerang shape, alar cartilage. People oftentimes forget about the intermediate crura, because in most people with normal noses, there's nothing to do about it. It's just kind of this transition point between the medial crura and the lateral crura. But in like boxy tip noses and other noses, it can be elongated. You might have to shorten it. You might have to adjust how it's creating a hanging columella. If it's pushing it down, shorten it. So I think that's something that's frequently overlooked on exam. And as you get to the medial crura, you're seeing, is there excessive foot plate flare? Are they sagging down, causing a hanging columella? Once I get to there, I kind of transition to the base view, looking at the flare of the alar insertion of the face, looking at the nostril size. Those two things are going to kind of dictate if I do alar base reductions, what type of reduction I'm going to do. And then, if you're looking into the nasal cavity, is there asymmetry in the nostrils? Usually that's going to now make me start thinking about my septum. Is there caudal septal deviation that I'm going to have to correct? So I have a nice stable platform to build the nose on. And then once we go in the septum side, I'm looking in the nose, doing my caudal maneuvers. Usually if there's nasal obstruction that's not obvious, I'm spraying Afrin, giving them a minute to see the turbinates come down. Does that improve their breathing? Do I see functional collapse while they're breathing as the internal external valve? Then finally, like that margin, is there any alar retraction? So I would say in about 20 seconds, those are like all the thoughts that race through my head when I'm looking through someone's nose and going through it with them.
Yeah. Does the skin on the nose, like how do you think of the skin on the nose?
Yeah, I look at it mostly when I'm thinking about my tip maneuvers. So to me, it's going to be mostly a counseling issue if I'm dealing with thick skin and someone wants a lot of definition. You have to kind of let them know there's a limit. And there's some things you can do afterwards, Accutane, you can do steroid injections to help thin that, but you kind of have to counsel them ahead of time. There's going to be a component after surgery that they have to do, and that's going to be one of the limiting factors. Thin skin patients, if there's a lot of contour irregularities, you should be mindful of that when you're doing hump reductions. And, I would really try and stay away from like dorsal onlay grafts. So I think there's a lot of surgical choices you make based on the skin. It doesn't necessarily change what I'm seeing. It might change my counseling a little bit. I'm also going to try and spend less time shaping the cartilages more if they have thick skin. I'm much more likely to kind of stack something on the tips to project into that thick skin, create the definition.
At this office visit, tell me, do you have any special tips for photo documentation? Is there, special programming? You discuss like a morphing program and things like that. Talk to me about that.
Yeah. So from a photo documentation, I vehemently believe that you need to have standardized medical photography. An iPhone just does not cut it. An iPad does not cut it. I know one of my residents felt differently on a prior podcast, but I think you can cheat the photos so much. And that might be great for marketing, but I think it really, one, does not allow you to be critical of your own work, to really understand what changed. Was it just the angle of the photo? Was it the lighting? They came in the morning one time and there's a window there, and the next time all of a sudden there's bright sunlight because of an afternoon appointment. So I use 2 soft boxes, each equidistant from where I'm shooting the photo, kind of at an oblique angle, ideally 45 degrees. Sometimes rooms don't allow for that, so you have to come a little narrower. Those are overhead and hanging off the ceiling. The backdrop color, I think, matters mostly to what skin tones you're operating on. If I like a white backdrop, I think it looks nice. But if I'm dealing with people with really dark skin tones, it really darkens it up. And so if you are operating on that population, sometimes a bluer background looks nicer. The camera prime lens, so you're not adjusting the focal distance, is super important. The iPhone cameras, they have a fisheye lens. So you have to shoot it from far away and then crop the photo in to kind of get rid of that distortion. So, and then they also, the reason they take such good pictures is the computer messes with the photos so much you don't even realize. I have a beautiful photo in my office that I took of this landscape in Montana. You'd think it was shot with like my fancy DSLR, like my other photos, and it was shot on an iPhone, And like when I went to go do the editing, I had to touch one thing, because it did so much work to make all of the exposure throughout the photo the same. And you don't want that. You want the same exposure settings, same ISO on the camera. So my settings I never touch. And that way, every single patient is getting this. I know no matter when they come in, what time of day that's happening. I also crank the flash up maximally so I can move the exposure as high as possible. So that way, when you take the picture, if you take a picture without the flashes going up, it'll just be black. There's not enough light coming in. So the shutter speed then doesn't matter. So I think a lot of thought goes in. It's not a well publicized thing. I know Dean Toriumi's book talks about it, and I called up one of his former fellows to find out what he did, because I think he's probably pioneered the most kind of sophisticated photography of rhinoplasty patients in history. So
what kind of camera do you have, Patrick, for work?
I just have a Canon. It's like a SL2 Rebel. It's not a fancy body, maybe a $400, $500 camera body. If you're buying a camera and you're listening to this thinking like, oh, I really want to get a camera, the focal distance of the lens depends on the sensor of the camera. So if you're using a cropped camera, which is like I think it's an ASPC kind of sensor, usually you're looking from like a 55 to 60 millimeter focal distance. If you're using a full frame camera, which is going to be your more expensive cameras where they have a much bigger chip in there to take all the photo, those are going to be, I think it's 100 to 110 millimeter focal distance. So just to be cognizant of that. You can find that out online.
That's super helpful, because I just remember, this is now, shows my age and date, but when I was a PGY2, we did our plastics rotation. And I remember working our plastics with our plastic staff at Jefferson, Dr. Ryan Huppelfinger and Dr. Krein, and taking the photos, was always the PGY2 job, but they'd have to always go and redo them every time after I took it, because I was just like, what am I missing? It's
hard, plus getting all of the angles consistent.
Yeah.
I'm always looking for like a hint of eyelash on my profile.
Yeah.
I try and get the nose almost even with the cheek on my 3/4. And then the fronts, I just try and make sure it's as level. And I kind of use the ears as my reference for all that. But I retake them all the time. I'm like, nope, I don't like it. I look after every single photo. But it's important, mostly for your image morphing. I know that was the other question, was like software that I use. I think image morphing is just a vital tool. It definitely made my profiles get exceedingly better once I started processing my images and going through it. Number one, it allows you and the patient to be on the same page. Patients will come in, say, I want less projection. And what they mean is, I want less rotation. Or I want, my nose up. And then you're like, you take it up 3 degrees, like, no, that's too much, And so like being able to suss out, one, that you're on the same page, and two, that they're not being so particular that you can't deliver because it's within the margin of error of the surgery. I think those are the most vital parts to it. It definitely helps patients wanting to proceed with surgery. I think there are people that use it purely as like, let me draw pretty pictures as patient books. And I think that's probably not the best interest of the surgeon or the patient, because they're going to end up being unhappy. And I think there's some dissatisfaction with being able to draw photos that you can't create in real life. I also do an overlay of the picture and preoperatively in my morphed image. And I take that with me as basically a blueprint, so that when I'm in there, it kind of lets me visualize how much bone am I taking down, how much cartilage am I trimming off. I think that's super, super helpful to kind of get the proportions right.
And then you just save those images once they're morphed, agreed upon. You've kind of gone through everything in the EMR, and that way you have your reference. You can think about it and then be able to, use it at the time of surgery.
Yeah, exactly. And there's, commercial systems that do this, and they're all, pretty expensive. Grant Hamilton published a really beautiful paper several years ago on basically how you can just use normal Photoshop to manipulate the images. Most of it's just the liquefy tool, moving the tip around on profile view. I've never found even like Vectra doing a really good job on the front view, because when you're looking at a nose in a photo, you're looking at light highlights and shadow contours. And from a profile view, when you have a set background, you can drag that around because you have this stark contrast where the nose ends and the white background is, or the blue background is, and get a really good looking image. When you do it from the front, you're trying to create light highlights that aren't there in the original photo and shadows that aren't there. So you have this broad tip with this dull light reflex off the tip defining points on a bulbous tip, and you try and create definition and move those light highlights in, and all of a sudden they're sharp, and that's how they look on the post-operative photo. But you can't really create that unless you go pixel by pixel. So I tend not to do forward image morphings. I just do profiles. And
when you use that for the profiles, do you use any arrows or markings? Like, you have picture A, then you have the second picture, but do you have to are you able to take notes, or, circle something, or, put an arrow somewhere just to kind of help you see what you did and to make those changes? Is that helpful? Or
to me, it's the overlay. So I take the preoperative photo and I turn it red, so that when I look, I see the morphed image with a red backdrop. So it really highly contrasts what I'm taking down. And so I can see how I'm bringing that in. I think so much of this surgery is about like creating a stable platform and then kind of making everything fit proportionally around it. So, most people come in, they want the same tip things, right? They want a more defined tip. They don't want a tip that droops. They want this kind of more triangular nose. There's some variation in that, but not a ton. What changes oftentimes is how much the tip dorsal relationship they want, whether they want a straight dorsum, whether they want a bit of a superative break, whether they want it more scooped out. And like, they can all look good. And it's just a matter of knowing what that patient wants. And once you see what you need to remove to create that, then you can kind of fit all the other maneuvers around it that you need to do.
Yeah. Talk to me a little bit about non-surgical options for rhinoplasty, and who is going to make, which patient group makes a good candidate for those?
Yeah, great question. So, fillers, the primary non-surgical option for rhinoplasty. The ideal patient for nasal fillers is someone with a low radix. They're going to do what the name says, right? They fill, they add volume. 95% of rhinoplasty patients, and especially in my population, I think if you're dealing with Asian population, Caribbean Islander population, you're going to get more benefit from it. Most of them want a smaller nose. Most of them don't want more in their nose. There's a reason that rhinoplasty in the 70s and 80s got a reputation as a reductive operation when they were just trimming cartilage, right? So most patients' fillers are not going to benefit a whole lot. And it creates these unnaturally large noses, these radix that are really, really high and kind of look more like a Roman nose. Think like Dimitri Martin. It's coming up because they're trying to smooth out the bump, but they're adding volume around it to do that. Now, I tell every single patient, there's a risk of blindness from this. I think once people hear that, they're like, oh, I don't want that. I'm like, yeah, I can do surgery that does not have a risk of blindness. But if we're going to start throwing something that can create an embolic complication to vessels that anastomose with, the ophthalmic artery, like that, it's a risk. And there's also a risk of tip necrosis. That the tip is very dense sebaceous skin. If you ever do Mohs reconstruction on the nose, you'll know that like the upper 2/3, you can pull the skin around a bit. As soon as you get below the super tip break point, like that skin does not move. And that's why we have these bilobe flaps, all these things where we are able to move that around, because we can't just close them by pulling them tight. And so when you start putting volume in there and it stretches, you start compressing this watershed vascular area. And, there's every meeting I ever go to, you always see these disasters from, injections. And you will find people that market themselves as, I do liquid rhinoplasty. And you'll notice that all the pictures that they actually put online tend to be low radix pictures. But I'm sure if they're saying that they're doing 1,000 of these a year or whatever number they're throwing out there, like there's not 1,000 patients with that morphology that are coming in a year. So I think that's just important to keep in mind. People are trying to feel like, am I not doing this stuff? What am I doing? I don't think you're probably doing anything wrong. I think it's mostly that, like, if you're being honest with what good patient selection is for it and you're counseling patients appropriately, you probably shouldn't be doing it like 10 times a week,
Tell me when you do decide. So when you are deciding to go to surgery, how do you decide if you're going to do a closed approach versus an open? Do you do any of these under local anesthesia? Is it usually general?
Yeah, usually general for me. I will do like little minor dorsal things under local. I think if it's just a isolated dorsal irregularity or a bump that I'm taking down and the tip is beautiful, closed rhinoplasty is a very reasonable option. I trained when I was in fellowship with Norman Pistoric, who wrote the book on he invented the transdermal suture. He like so many of the seminal papers in the 70s, like he published on how to do closed rhinoplasty. And my takeaway after spending time with him and people who are just phenomenal open rhinoplasty surgeons, Spencer Cochran, Dave Rosenberg, going and watching Dean Toriumi's work, like my takeaway is that closed rhinoplasty is a flawed surgery for the tip. The main reason is you cannot see the tip in its natural state. You cannot see those cartilages without delivering them, without moving them around. And then your suture placement is at best guess and check work. You're seeing, okay, here's where it is. I think this is where it goes. I throw the sutures to the other side. I bring the tips together. I pop them in. I look. No, that doesn't look right. I didn't move them this way. And then you have to keep delivering them and doing that. And it doesn't allow you all of those three-dimensional anatomy things I talked about earlier. It doesn't allow you the ability to change those. So yeah, and like in a very like pretty good tip, and all you want to do is a transdermal suture, and that's what your comfort level is, then sure, you can make that work. But I think the vast majority of tips, I can see really beautiful dorsal changes with tips that are leaving things to be desired. And I say that going to meetings where there's sections and I go sit and I see like, what are the best guys doing? Like, am I missing something? And I still see this in their photos that are put up, that the tips just, you cannot do the same things with tip support, with tip definition, with a closed rhinoplasty. And I would say the majority of my revisions that I do are on patients that have undergone closed rhinoplasty, have a dorsum that's brought down, and are super unhappy with their tip.
Yeah. Well, let's talk about your approach to the nasal tip. I recall a grand rounds that you may have given during residency. There may have been a part 1 and a 2, but I do recall. So let's get into how you think about it and how you address it. You'd mentioned, in the beginning when you were talking about your analysis about cephalic malpositioning and all kinds of things. So let's go into sort of, how you think about it, and are there special instruments that you like, or sutures, and, how you address scissors? How do you address it?
Absolutely. So, to me, the first step in rhinoplasty, like in addressing the tip, is just forensic rhinoplasty, as what I call it. Like when you open the nose up, like you have to look at how those tip cartilages are constructed and see if all the assumptions you made based on the way the nose looks are correct. So, one of the challenging things is people have a way, I do tips this way. You can't do this this is the way I do my tips every time. They're all different. And so you have to come in thinking, okay, this is what I thought was going on here, but look, all of a sudden I see this really concave, lateral cruce, so on the left and not on the right. And I thought the septum was deviated to the left, and that's what was driving this tip asymmetry. And you have to pivot and understand what changes you're going to make. So, I think that's the first thing. You have to kind of verify that the cephalic malposition and that kind of short axis rotation I was talking about are correct with the lateral crura, and then make sure that your plan is correct. So I think that's where it starts. You come in with the plan, you double check your plan once the skin's up, and you do that in a way with no retraction on the nose. You're not pulling, you've just folded the skin back and you're just looking at them, laying how they live on their face and making sure that's the same. I usually then am going to start by getting the height of the lateral crus to where I want. So a lot of people, that's going to be a cephalic trim. If it's a really concave, collapse kind of inward lateral crus, I'm going to do a turn over flap where I score that, dissect the cephalic trim piece off so it's still attached, fold it over. So now you have these two curves that are opposing each other, and now they flatten out the crura. And that's not going to be as thick as septal cartilage. It's going to be the cartilage that's supposed to be there. You're making this laminated lateral crus that just creates strength. So you're not only taking away volume from where you don't want it and cartilage from where you don't want it, but you're strengthening where you do want it. And the unfavorable curvature of the lateral crus, you're correcting with the equal and opposite curve, essentially. If it's the opposite, which is more common, where it's convex, I'm dissecting the vestibular skin off, and I'm doing the same thing by folding it under. As long as you have enough. If you only have like a 2 or 3 millimeter piece, it's probably not worth it because you'll be able to correct it with sutures at the end. But if you have, 4 or 5 millimeters that you can fold under, then you're probably in good shape. So I'm usually leaving at the widest part about a 7 millimeter strip there laterally. And I think that's regardless of what technique you're doing, what you should leave. And I think that's pretty agreed upon in the literature that, sevens, you're going to have a pretty stable lateral crus with that. When you fold that under, I'm making sure I dissect it widely enough that it's not causing it to tilt or some weird way that it's pushing the vestibular skin. So that's really crucial. And then I'm placing my intradermal sutures. So I'm thinking, do I need to do a lateral crural steal? I can tell you from just earlier in my career, when you place those, you want to stay in that dome curvature region of the cartilage. When you go really lateral to that, it can do weird things. Every now and then you're forced to, but it's pretty rare. Usually you want to stay in that curved part so you can sharpen it some, but it's not creating this really hard bend and this really angular kind of dome region. It still should have a bit of a curve to it. And then, make sure they're not perfect every time. Watching Dave Rosenberg, who, literally has been doing this for 20 something years at a super high level. He frequently will put the dome sutures in and not like it and move it a millimeter, put a mark with, where the dome is folded, where you don't like it. And then that way, when you go to throw the second stitch, you can know where it's moving. So that's really helpful. So you don't lose a reference. And then, once I've done that, I'm kind of going through the rest of my nose. It's kind of getting it just in the ballpark of when I need to play with it. And then harvesting my septal cartilage and then doing some sort of tip supporting graft. I'm a big proponent that you need something that extends from the anterior septal angle to your domes. If you don't, this is where you frequently see these 2-year collapses, these noses that super rotate because that just collapses. And a lot of people do tongue and groove sutures and think, oh, this is strong enough. But if you don't have a really large, prominent anterior septal angle, like a tension nose deformity, rarely do you have enough cartilage to just carve that into this kind of configuration and rotate it up. So it can be a Collier-Miller strut, and Spencer Cochran is just a master at using a Collier-Miller strut. I spent probably 2 years trying to replicate what he's able to do, and he's just super talented at being able to create this very nice Collier-Miller strut graft that gives so much support by kind of partially tensioning it into a soft tissue pocket, having it extend from the nasal spine all the way up to the domes. And the upside of that is it allows you to offload the weight of the tip from the L strut. If you're doing a caudal septal extension graft, which is what I tend to do, you definitely have to leave a thicker L strut on the dorsum, and especially tapering it wider towards the keystone region. If you think about it from a structural engineering standpoint, if it comes down a little bit more and it widens towards that keystone area, you end up gaining a lot of strength in it. And so if that's where the weight's going to be, that was kind of one of the hardest, I think, transition points for me. Was I was used to being really aggressive at getting all this cartilage to carve these big Collier-Miller struts, and now I need less, and I'm having all this extra cartilage, but then I'm having to take ethmoid bone grafts and things like that to reinforce the L strut, because when I go to put that tip on there, it wants to flex the L strut some. So kind of be cognizant of that as well. And then once I get the tip rotation and projection right, then I'm kind of thinking like I attach with a transdermal suture to bring them all together. I'm using an equalizing stitch at the cephalic portions of the dome, so you create that nice diamond-shaped appearance. The infratip I'm bringing together. And then I frequently use a spanning stitch to take out that last little convexity where it kind of goes from a little bit behind the dome's lateral cruce down to the septum and back up, so that you don't tighten that all the way down. It's just there to hold it in place so that as the skin soft tissue envelope heals down and scars in place, it creates the shear force. It'll take that last tiny bit of convexity out.
There's a few questions I had just to kind of unpack it for me a little bit more. Super helpful, your explanation. When you get into the OR and, you're doing initial exam, like, hey, is my plan what I initially saw in clinic? Is this the plan based on what I physically see now that I have the cartilages exposed? Do you find that, I'm thinking, like, is it going to be harder? Is that correlation going to be less consistent in a thicker skin individual? Like, are there risk factors where you're like, the likelihood of me having to, change it up a little bit is going to be higher in this? And are there certain characteristics?
Yeah, no, that's a great question. I mean, I think when there's tip asymmetries, the bag is like wide open, right? Like I found tips where they've been one dome on top of the other, and you were like, what? You're starting to open it up and it's driving away right and back left. And you're like, this is bizarre. Thick skin patients, they tend to have these kind of C-shaped cartilages because the skin dominates what's going on there. So I find that the cartilage matters less in thick skin patients, just because, you just want to create a nice foundation for you to like build that tip projection into. But I would say that the asymmetric patients are the ones where, you can kind of make a guess, but when you get in there, it's frequently some curveball thrown your way that you're going to have to account for.
And then some basic questions about, in terms of instruments and sutures, is there a certain scissor or blade that you like to use when you're trimming cartilage? What's on your back table?
Yeah, so I think the one thing that's outside of most normal rhinoplasty sets that I love is I have a sterile tongue depressor. That sterile tongue depressor I can hold in my hand, put my thumb on the cartilage, carve it with a 15 blade right there. You see all these like fancy, non-slip things are like hanging over the back table like this, trying to cut it. And it's just awkward. And it's like, if you think about it, like whittling wood, the ergonomics for that, the reason people have done it like that for centuries is a reason. If you hold the cartilage there, you can really shape it accurately. You can cut down. You're not going to cut yourself. It's not going to dull the blade up, hitting the metal, and then you got to get a fresh blade to keep cutting the cartilage because you've been hitting this aluminum backstop. The wood's nice and soft. And it doesn't slip. It has a nice texture to it in terms of like being able to put it there. It doesn't want to slip off like it does those aluminum plates. So I think that's like kind of probably the biggest trick. I love for cartilage harvesting a Woodson elevator to first get in that subperichondrial plane. That was an instrument that I found in fellowship that like changed my life in terms of, getting that plate up consistently every single time with not tearing flaps. And then same thing with swivel knives. I love swivel knives for harvesting the cartilage instead of trying to like look down there and stretching your flap out and tearing it. So I think everything else there's no crazy secrets. So on mission trips and things like that, we've literally done rhinoplasties without speculums before, for like cleft rhinoplasty and things like that. And you can do it. It's not fun, but you can do it.
Talk to me about your sutures. You had mentioned domal stitch and an equalizing stitch and a spanning stitch. What kind of sutures do you use?
Yeah, 5/0 PDS for pretty much everything, with the exception of if there's a lot of medial crural footplate flare on the base view here, give you that kind of little step on the nasal sill. Those I will put a 6/0 Prolene back and forth on, and then hit it with a little betadine before I close the skin over it. That's the only permanent suture I use in the nose. I close my inverted V incision with a 7/0 Vicryl, which is a game changer. Everyone I've ever trained with has always used a 6/0 Prolene or something, a nylon or something like that. And the problem is you get the skin overgrowth and it's miserable for you and the patient trying to trim them out. And so the Vicryls, they're so thin that they don't cause any real inflammation. I mean, I've seen one left for 3-4 weeks and like it didn't cause any extra scarring or anything like that. And you can just trim them flush with the knot and let the little loops stay under and dissolve away. And they work wonderful. So I really like 7/0 Vicryl on a P1 for that closure. 4/0 Plane for quilting the septum typically, and then 5/0 Chromic for the marginal incisions.
And then in terms of getting cartilage, I imagine, especially with the revision cases, you don't always have enough septal cartilage. What's your go-to when you have to get an alternative spot? Do you, if it's ear, is there a side that you usually prep out?
Yeah, ribs my go-to for the revisions typically. Ear, you can't really get, to me, like usually the failure point in a lot of revisions is the tip supporting graft. So caudal septal extension graft, usually going to be my workhorse there. But the ear cartilage is too floppy. It's that fibrocartilage, and it kind of crumbles. So that curvature just won't work. You need something straight. So I take a dermatome blade and I cut the rib cartilage into thin sheets. I add some water on the back table. I let it dry so I can see which ones have a lot of warping tendency and which ones don't. Sometimes I'll divide them down the center, just like I was talking about earlier, and laminate them into a 2-ply so that the warping tendencies oppose each other. I do cadaveric rib as well as autologous rib. So it just depends on patient preference and age. If they're over 50, I'm not going to harvest their rib. It's going to be too calcified. But in a 30-something-year-old, that's fine. But a lot of people prefer the cadaveric rib. And I think if you're not using frozen rib, if you're using one of the kind of room temperature ones, they hold up pretty darn well. I know a lot of people that use them and love them. I think that's the frozen ones are the ones I've always heard complaints about. And it makes sense. If the rib has to be frozen to not have problems, then when you put it in a body temperature person, I'm probably not going to hold up that great in the long term,
That makes sense. In terms of the dermatome, so you have either the cadaveric rib or you've harvested autologous rib. And then on the back table, you have a dermatome and you're kind of getting...
Just the blade from it.
I don't use
the dermatome itself.
Okay. And is there a certain size blade or is it pretty standard that comes in? Okay.
I think it's pretty standard. It's basically a big razor. You can use any big, long razor blade that you can fit in your hand and put pressure downward on so it cuts a straight, even line. I just put that over a blue towel on the back table so I have something to cut into that's not going to cut the drapes. And that way you can get a bunch of slices for spreader grafts, rim grafts, whatever you need. And then I usually try and leave maybe a third of it, just so if there's some weird curved graft I need, I have the side of it to carve that out of. Uncommon that I'm doing that. That's a once in a blue moon sort of thing. But I have had the situation come up where it's if you cut all the slices and then you're like, crap, I need something thicker, and you've already cut them all, you're kind of annoyed by that. So it gives you some free range, and having that option is helppful.
When do you use implants or splints? When do those come into play? What are your thoughts on that?
No, great question. Splints, if I get a tear in the mucoperchondrial flap, that's typically where I use. If it's a tiny hole on one side, I put a stitch in it and don't worry about it. I'll still quilt them. But if you get a kind of that typical linear tear that forms, especially in a really deviated septum, those are the ones where, one, they're going to get a lot of bleeding. If you don't splint them afterwards, you're going to drive them crazy. Two, you can high risk of septal perf problems because it's just got to be injured. So I want that silicone material over them to help. But other than that, I really try and avoid them if I can and just quilt. And I'm also rarely going and elevating much over the bony part of the septum. And these, cosmetic noses where they're just not crooked, I don't have to. And that makes their post-operative pain better. It makes the bleeding better. It makes everything better. So if you can avoid, once you get to that bony cartilaginous junction, kind of just stopping right when you first feel bone, you'll find that they heal a lot better in terms of just everything. The implants of the nose, I'm very opposed to. I don't think that non-viable tissue or non-viable things belong in a nose. The skin's too thin. I mean, think about a breast implant. You have the pec muscle over it to shield it from extrusion. You don't have that in a nose. And I've seen so many patients that I do these pro bono because I don't want, they fly over to Thailand or something. They get a nasal implant put in. They come back, it extrudes, and there's no one to take care of them. So with these, I'm just I take them out because it's just a disaster for their nose. And when you do anything in surgery, and especially in cosmetic surgery, I think you have to look at, one, what's the likelihood of a complication and how catastrophic is that complication. And even these people are it happens 1% of the time. 1% of the time of a thing extruding to the tip of someone's nose is unacceptable, in my opinion. And it's not, once that happens, you can't repair that. If your solution is paramedian forehead flap for cosmetic surgery, don't do that surgery. The tissue is just irreplaceable. So I think that's a very difficult, challenging rhinoplasty to do, because I get you go from a 45-minute, I'm making a pocket endonasally, I'm popping an implant and they're closing it up easy, versus I'm getting rib, I'm getting temporalis fascia, I'm doing a diced cartilage fascial graft to augment the dorsum. Like, it's a lot more work. So I get the temptation, but you're like, hey, 95% of my patients are happy. And it's like, yeah, but the 5% that aren't, it's not that they're like, this isn't up well. It's that they have a thing that's infected and sticking out of their nose. And like, I don't think that's worthwhile, in my opinion.
In terms of other factors, such as age, you'd kind of, mentioned age when it came to the type of rib graft you might use if you had to. But how do factors like age, gender, race affect your approach overall in rhinoplasty, whether it's analysis, intra-op, post-op?
Yeah, so age, I think from the top end of the spectrum is mostly if it's a revision case, whether I'm not going to use rib or not. The osteotomy is also tend to be much more likely to create a non-green sticking fracture and fall in. So you have to be aware that you can hypermobilize the nasal bones. You might have to support it with some Surgicel or something. So those osteotomies, if I can avoid them in older patients, I try to, but sometimes your hand is forced and you have to do it. Younger patients, I think the youngest I've done rhinoplasty on is like a 15-year-old girl. And then for boys, it tends to be more like 17, 18, just from an emotional maturity level, facial growth level. And then as far as race and ethnicity goes, you have to be respectful of what their wish is. It goes back to this, there's not an endpoint, right? Like, I'm not here, like, the thing I'm most proud of when you look at my, catalog of photos is like, the noses are not the same. It's not, that's a Pat Cleveland nose. It's like, no, they look natural and they look like they fit their face. And like, it's because you take the time to understand what their goals are, where they're starting from, what features they want to preserve, what features they want to change. And, if you do that, then you're going to end up respecting those, those ethnic preferences, whether it's the nasal base width, whether it's how much of the dorsum to take down, especially, Middle Eastern male rhinoplasties, a lot of them, they have a big, huge kyphotic hump and they don't want it straight. They just want a really subtle hump, and that they're happy with that. The nostril size, like, it might be that they still have wide nostrils on like an African American nose, but they just want less flare, so it's not as wide. They don't want it super, super tiny with these aggressive, unnatural looking alar base reductions. So I think it's just, if you're doing something that's really, really aggressive, you have to ask yourself, is this the right thing to do? Same thing with asymmetries. If you have an asymmetric problem, you got to do asymmetric solutions to it. So if you're like doing one thing on one side, one thing on the other, and they're different sides, you're probably doing the right thing. If you're taking tons of tissue out of the base, like, you better know for sure that one, the patient's gonna be happy, and two, it's gonna look right, because I think you're much better to come back and take a little more later.
In terms of rhinoplasty for gender affirming care, has that been part of your practice? And tell me about some of those nuances.
I haven't had that actually in my practice. Probably mostly a microcosm just where I practice. Probably see more of it. But I haven't had any patients, so I don't really have unfortunately a really good explanation on that. I think going through, you have to, one, kind of follow the same principles. If that were to come up, I would be making sure that, one, they're emotionally ready. Whoever the doctor is kind of like leading their transition, I would make sure that I have a letter saying that they're comfortable with this. And then, I think when you go through the images, you're going to see like what their preferences are. I think that part doesn't really change. I have female patients with masculine noses that I feminize, right? I don't really have female patients with feminine noses that I masculinize, but I would imagine that it's very similar to when you deal with an Asian rhinoplasty or Caribbean Islander rhinoplasty, where you're going to be augmenting the dorsum to kind of straighten it out if it's this small, petite, scooped nose. So the techniques you're using to get to specific endpoints are going to be similar. The sequencing of them all is going to probably change to a certain degree based on what you need to do. But it goes back to just having the conversation with the patient, taking the time to figure out what they want and what makes them happy and comfortable looking in the mirror.
Tell me a little bit about your post-op care. When do you see your patients back? When do you let them go back to work or to the gym? How do you counsel them with swelling post-op?
Yeah, so cast stays on usually 6 to 7 days. Nasal saline sprays, minimum 4 or 5 times a day, as much as they want. If they burn through the whole bottle in the first week, the happier I am. I have them do hydrogen peroxide on a Q-tip just over the inverted V incisions, just when they come in, they're not all gunked up with blood. I call them all the day after surgery, making sure that they're doing okay. If there's ever any concerns, you should bring them into clinic and look. Nowadays, frequently people should just send you a picture and like, is this little bruising normal? Yes, no. Usually there's a gauze, like a drip pad underneath the nose. I tell them all, it's normal to have that for the first day or two. As long as the thing's not turning completely saturated with blood, if you're changing it every 3-4 hours and there's red spotting on it, that's normal. And when it stops, you can take it off just so you don't have to keep tapping the nose. Nothing heavier than 10 pounds for 2 weeks. After 2 weeks, the nosebleed risk, I think, is pretty minimal. They want to start working out, advance in a normal manner. Don't go back to trying to like bench max weight in day 14, but they want to get back in the gym at that point. That's fine. And I'd have them avoid any sort of contact sports, basketball, things where a ball's flying around that could decide that their nose is where it wants to land. That's a big no-no for 6 weeks afterwards. At that point, the bones are healed enough that the chances of it breaking is basically the same as it was before. It's 80% as strong as it was at that point.
And then what about like post-op swelling, not just in the immediate post-op, but how do you set expectations in terms of swelling over the first, 6 to 12 months? I
don't have a lot of, I feel like, issues with swelling. I'm serious. Like, I think that's one of the reasons patients like frequently come to me. Like, I know on my Instagram, there's like all these videos of patients with their cast coming off and their noses look great, but that's like, I would say 85% of the time how it does. And I think a lot of that goes back to tissue handling and plane discipline. It was not always that way. I use tranexamic acid during my cases, which helps a lot with bruising and swelling. But when I first started using it, it wasn't like that much better, and I couldn't figure out why. And I think it's because at that point I would like do my marginal incision, make a little pocket above, and just kind of cut through the tissue. And then literally the difference of like taking the extra 30 seconds to like elevate all of that tissue off in that suprapericondral or superior plane so that all the muscle comes up, like that is so much, it makes so much difference. And if you think about it like your ankle, if I can lean my ankle and twist it pretty far over and come back nice and slow and gently, I don't have an issue with my ankle blowing up and swelling. If I roll it the same distance really quickly, I now have a swollen ankle that's bruised up for a couple of days. And I think people try and operate as quickly as possible to do as many cases as possible sometimes. And if you treat the tissue gently and you're always just putting just the amount of tension you need to get the visualization you need and no more, you're elevating in places where you can spread and you're not cutting, like you're going to have noses that swell less, that have less issues. I tell them usually when the cast comes off, it's going to swell a little more now that the tape's off, but most of that goes down over the next 3 weeks. And by the 3-month part, the vast majority of the swelling's gone. There's thick skin patients hold on to it longer because mostly the skin memory is the issue and you're waiting for the scar contracture to occur. So I think that's the biggest difference in conversation that I have with the thick skin patients. So I'm like, we're going to be doing steroid injections down the road to thin out that skin soft tissue envelope. For them, it's really a year process to, I think, get a really nice result. But typically, it's still looking better by the 1 to 3 month mark.
That analogy is a good analogy. Tell me a little bit about how you counsel patients on potential complications, whether it's, usually obviously the conversation happens ahead of time.
Yeah, when I go through the consent with them, I usually, just say, listen, most common thing patients get from this is nosebleeds afterwards. It's mostly a nuisance problem. Usually we can stop with pressure. If not, I see you in the clinic and we can fix it with, some hemostatic things. Infection is the next most common thing I worry about. Usually it's some folliculitis as the hairs are growing back after your vibrosectomy, week 3 to 4, in which case we do some Bactroban ointment in the nose. I have them put Bactroban ointment in their nose 2 days pre-op all the way through 2 days post-op twice a day, just because half the people in the world have MRSA of some sort in their nose. So it's like not worth culturing them. It just killed on everyone. And then I kind of go through like the more rare things, septal perforations, having wound healing issues, contour irregularities. I say like, listen, there's the part of the surgery that I can do on the table. And I firmly believe you do your revisions on the table. I've multiple times had sutures, I'm closing, telling anesthesia I'm getting ready to go. And as I'm closing, I'm seeing something that I don't like. And Spencer Cochran drilled into me, and this is because Jack Gunner drilled it into him. You open the nose up and you go look at it. And, if you're seeing something, don't just push on it and think, oh, that'll buff out. Yeah, that'll shake out. It'll be okay. Look at it. And if you look at it and everything underneath looks fine and you feel the skin soft tissue envelope and there's not some bump of cartilage actually cut off, stuck up there that you weren't seeing, you put it back down, then like, yeah, it probably will. But, until you're sure, like, don't leave it for tomorrow to be a problem. And I think if you do that, your revision rate is going to be low, and the risk that these wound healing issues occur is going to be less than because you're setting them up for success.
In terms of follow-up, you see them about 3 to, when the cast comes off at like 3 weeks, and then how often do you follow them?
This cast comes off at 6 days. So I see them, no worries, 6 days. I see them at 6 weeks, 3 months. And then 3 months is kind of a transition point. If everything's looking great, I'll see them, if I have seasonal patients that are down here and they're gone for the next 6 months, I'll see them at like the 9-month to a year mark. If they're local, I usually see them at 6 months and a year.
And do you take photos at every visit post-op, or when do you bring back the post-op photos in?
I always, for medical legal reasons, take them initially, show that like, hey, it's healing okay. And then usually like the 3-month is the first, like, I feel like really good photo, but sometimes it's earlier that I'll get where it's like, okay, this is a fair bit. If there's obviously an issue that I want to track, I'm going to do it every single time. But if everything's going reasonably well, I don't think you're ever wrong taking them every time. But if, you miss the 6-week one, things are moving along as normal, and you have that initial one, I don't think you're going to be burned by that likely.
And so as we start to round it out, if you have any final thoughts or pearls that you want to leave us with, or, any thoughts on, what you've seen and how rhinoplasty technique has changed since you started your training in the last, 10 years.
Yeah. I think I know you have a fair number of residents that listen to this podcast, and there is a kind of method of thinking through noses that I learned at NYU that they teach the residents there called the DESS, DESS. You can look up the paper published by Judy Lee and Anna France, as well as Phil Miller and Manas Constantinides. They were all on that, and I think Matt White as well. But the really great thing they pioneered there for resident education, it stands for deformity, etiology, solution, and sequence. And it's basically an idea of how you think through a nose. So each time you see a deformity, tips bulbous. Okay, what's the etiology? Okay, the cartilages are prominent, there's convexity to them. Okay, what is your solution? You do a cephalic trim, and I'm going to put transdomal sutures in. Okay, where are you going to sequence that in your surgery? So it forces you to kind of think through all that. So what I used to do as the fellow is, like, all of my cases, I didn't send the photos to the resident, and they would have to go through weekly, do all of this, review it with me, and then they would, on Thursdays, would present it to Judy Lee, who's the director of facial plastics over there. And it really, from an oral board standpoint, makes you like think that it's the easiest thing. It's just like cake work to go through. So for residents, I think it's super beneficial. For people who are looking for a more formalized way of thinking through rhinoplasty, it's not just from boards. It's literally like what I just do in my head now. So I think that's super helpful. And then as far as things have changed, I think the biggest thing right now that's going through that people are kind of talking about is preservation rhinoplasty, kind of an old technique that's been reinvented, but it's got a lot of traction, especially since, I know Dean Toriumi has really taken it on. And I think it definitely holds merit in patients with these really big humps where you're taking it down and you're losing those dorsal contours. It's not my patient population per se, but, you see some of these really aggressively large noses. I can see how it could be super beneficial. I think also if you're using, a really cartilage, heavy rhinoplasty, it can be, and trying to reconstruct the midvault and things like that. It can be really, really helpful because that becomes a really challenging area if you're really taking it apart fully. I try and leave some mucosal attachment between where I elevate for my chondrotomy, where I take my cartilage out, and where I'm going to put the actual spreader grafts in. And that's not how I was originally trained. When I was at Southwestern, we would just kind of undo the whole upper lats, and then they fall down. You see them fall down in the case. And then now you're like, okay, now I got to pick them up. Where do they go? I put them here, and you got to use bigger pieces of cartilage to support them. So if you leave even the slightest 2 millimeter bridge of mucosa there, it's amazing how much they stay up. And you can put a little spreader graft up there. And so I think that you're dealing with that issue, then being able to like leave the whole dorsum intact and move it around makes a lot of sense. So, but like anything, I think that execution matters as much. So I think you see very famous people get up and have beautiful results. You see very famous people get up and not so beautiful results. And, I think it's like anything, you have to execute it well to do it. So I don't think just doing preservation is going to fix everything for everyone. It definitely has its pros and cons.
Well, thank you so much, Patrick. It was so great to see you. I always call you Patrick. I can't help it.
It's okay.
Even when you call me, I'm calling you like, Patrick, what do we got to go do today? What are we going to go do now? Anyways, thank you so much. It was wonderful to catch up. I learned a ton. If any of our listeners wanted to get more information or reach out to you, can they find you on social media?
Yeah, absolutely. So social media is at Dr. Patrick Cleveland, and I really don't check DMs, so don't try and DM me. I'd rather you email the website, so drpatrickcleveland.com, info at drpatrickcleveland.com. You'll be able to get a hold of me that way. So
awesome. Well, thank you so much. I think it's a wrap.
Absolutely. Thanks, Gopi. I really appreciate the time coming and chatting.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable ENT on Instagram, LinkedIn, or Twitter. BackTable ENT is hosted by Gopi Shah
and Ashley Agan.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles, Nick Shellcross,
Josh Spencer.
Design and digital marketing led by Brian Schmitz, with support from
Taylor Spurgeon Hess.
Social media and PR by Chi Ding.
Administrative support provided by Jamila Kennebrew.
Thanks again for listening, and see you next week.